This is the hsCRP Insights for Healthcare Professionals Vodcast Series, brought to you by the American Heart Association. Lifelong learning. Listen, learn, and increase your knowledge on hsCRP and systemic inflammation.
Welcome to the American Heart Association's hsCRP Insights for Healthcare Professionals vodcast. My name is Paul Ridker. In this introductory first vodcast, I'll be talking about inflammation and high-sensitivity CRP in primary and secondary prevention. My goals in the next 10 minutes or so are really to take you through why would you measure hsCRP, try to get past some misconceptions about variability in this biomarker, talk about how powerful a predictor this really is of primary and secondary prevention events, and then give a very quick overview of treatments and guidelines that are changing related to inflammation and hsCRP. I have a variety of conflicts related to this. My research group has been focused for the last 30 years on one fundamental question: can targeted anti-cytokine therapy reduce cardiovascular event rates and prolong life? We now teach our medical students in Boston that atherosclerosis is both an inflammatory disease and a disease of lipids, not just a lipid disorder. We now teach these two processes work together to drive atherosclerotic disease. And on the right-hand side of the slide, you see a canonical cartoon of a complex biologic pathway known as the NLRP3 inflammasome pathway, where certain cytokines, in particular interleukin-1 and interleukin-6, are activated. This leads the liver to put out the biomarker that we're interested in today, known as high-sensitivity CRP. And there's a variety of ways of intervening on this that we now know can lower rates of heart attack and stroke. First, the high-sensitivity CRP assay has been available now for a long time. As you can see in this graph, levels of hsCRP going from very low to reasonably high are strong predictors of future cardiovascular events. And for purposes of clinical care, values less than 1 milligram per liter is generally considered lower risk. Values of 1 to 3 milligrams per liter generally considered moderate risk, and values of 3 and greater, higher risk. It is true that if the patient is in the midst of an acute phase response, has pneumonia, or is hospitalized, you could get a very high value. Throw those out. What you want is to measure this when the patient is stable and feeling well. In that circumstance, there's almost no variability we have to worry about, and the median value is around 2 milligrams per liter, which is used in many of our clinical trials as an enrollment criterion. Shown here is some evidence that we learned many years ago about the stability and the variability of tracking over time to make the point that it's actually quite similar between hsCRP and LDL cholesterol as long as you measure the hsCRP when the patient is stable in an outpatient setting. These data include almost 9,000 participants in the Jupiter clinical trial who were tracked over 5 years and were taking placebo. And as you can see, the variability and the interclass correlations are almost identical between CRP and LDL. So the first lesson here is variability is actually not a problem as long as you measure this when the patient is stable. Let's take a little walk through history. All the way back in 1997, we published the first paper about low-grade systemic inflammation preceding, by many years, the onset of cardiovascular events. These data came in the New England Journal of Medicine in 1997, and you can see in the lower left that increasing levels of what we now call high-sensitivity CRP were strongly predictive of future cardiovascular events. And in a bit of luck, this clinical trial was done on an aspirin setting, an anti-inflammatory drug, and you can see that aspirin modified this effect. This would lead to getting us where we are today. New guidelines saying, can we screen for CRP? And if so, what will we do about it in terms of anti-inflammatory therapies? You should be aware that many years ago, working with my colleagues Aruna Pradhan and Howard Sesso, we also showed that hsCRP is involved in a variety of metabolic disorders. These are just early papers, again, over 20 years ago, showing that CRP and IL-6, the downstream cytokine, are predictive of incident type 2 diabetes and are predictive of developing hypertension. So we're talking here about a very powerful marker of metabolic dysfunction. Now, just a few weeks ago, we published brand new data in the New England Journal of Medicine. These are presented at the ESC in London. of 30-year follow-up data in 27,939 initially healthy American women who back in 1993, in a random blood draw, we measured CRP and we measured LDL cholesterol. Let me first show you what the CRP survival data look like over 30 years. This slide shows 10-year data for increasing quintiles of CRP, 20-year outcomes, and 30-year outcomes. So the first lesson here is we need to be measuring this much earlier in life. If we can tell with a single random blood draw what the likelihood of having a major cardiovascular event is 30 years later, this is a very powerful way of thinking new about how to predict risk. Let me now compare this to the same values for LDL cholesterol, which all of you measure routinely. LDL is terribly important. I'm a very aggressive LDL lowering physician. But look on the left-hand side, you see the 30-year data for LDL. It works. But compared to the 30-year data for hsCRP, the spread is actually smaller. The argument we're making today is measure both of these. They represent different biologic processes that are telling you a lot about why your individual patient is at risk. That's the data for first major cardiovascular events. This is the data for ischemic stroke, again, in these 27,939 initially healthy American women, followed for 30 years. And once again, if anything, the hsCRP is actually a more powerful predictor than our gold standard LDL cholesterol. That was primary prevention data. Now let's talk about secondary prevention. These are data that were published in The Lancet a year and a half ago now from 3 major contemporary clinical trials, which include 31,245 patients taking statin therapy, because of course, they're all secondary prevention patients. These 3 trials, prominent, reduce it in strength on the left. You can tell in each trial that the black bars, the hsCRP, is more predictive than the white bars, LDL cholesterol, for, in this case, cardiovascular death, the most feared outcome among our patients. And in the meta-analysis you see on the right, a very big difference. Once again, of course, we want to measure the LDL cholesterol. It's crucially important. But if we're not measuring hsCRP, we're missing the enormous opportunity for therapy. So, clinical lesson number 1, hsCRP, a biomarker of silent vascular inflammation, is a stronger predictor of future cardiovascular events than LDL cholesterol in both primary and secondary prevention. Number 2, doctors will not treat what they don't measure. We need universal guidelines recommending to screen all patients for hsCRP, just as we screen for cholesterol. What about treatment interventions? Well, the Jupiter trial was published in 2008, quite a few years ago, telling us that statins are highly effective in primary prevention, even when LDL cholesterol is already low, but hsCRP is high. In Jupiter, you could enroll in this trial if your LDL was around 100. You would not qualify for a statin in primary prevention, but your hsCRP was greater than 2. And as you can see, the random allocation to a statin, rosuvastatin, reduced the risk of the primary endpoint by 44%, myocardial infarction by 63%, stroke and revascularization cut in half, and all-cause mortality down 20%. So the first lesson, of course, is if you've got an elevated CRP in primary prevention, you should probably be on a statin, irrespective of your LDL cholesterol. In secondary prevention, it gets really complicated. All of us are very aggressive about lowering LDL, which certainly works, and we all want to do that. But these are the anticipated benefits of ezetimibe, PCSK9 inhibition, and anti-inflammatory therapies following aggressive use of statins. And as you can see on the far left, we get a reduction with ezetimibe, no doubt about it. We get 15% reductions with PCSK9 inhibitors. On the right, however, you see the data from our CANTOS trial using canakinumab, about a 15 to 70% reduction. And then you see on the far right, the larger reductions associated with low-dose colchicine. So this is a challenge for us. Yes, we want to lower LDL, but why aren't we thinking about anti-inflammatory therapy? So clinical lesson number 2. In both primary and secondary prevention, all patients with elevated hsCRP should be strongly considered for statin therapy, irrespective of LDL cholesterol. And in both primary and secondary prevention, outcomes are improved among statin-treated patients who achieve low levels of both of these biomarkers. European guidelines just changed, At the ESC, many of us were there in London, and two fundamental changes occurred. First, a class 2A recommendation, which in the European system means should be considered. A very strong recommendation was made to give low-dose colchicine at 0.5 milligrams to reduce the risk of myocardial infarction, stroke, and need for revascularization. That's exactly what the US FDA said recently. That's exciting for us. That means we have the first anti-inflammatory therapy approved in the US for use to reduce cardiovascular events. And of course, as many of you are aware, in collaboration with Novo Nordisk, we're running a series of interleukin-6 trials that we're very excited about. Second big change in the guidelines is in the bottom half. Again, a two-way recommendation in Europe has been made that hsCRP should be universally considered in secondary prevention. I am confident the US guidelines will follow suit quite shortly. So all of this gets to this fundamental question about residual inflammatory risk. My clinic, like most of yours, is filled with atherosclerosis patients who have elevated levels of LDL cholesterol. Because I measure their hsCRP, I'm aware of who also has an elevated CRP. They get statin therapy, and the question becomes, what do we do next? Residual cholesterol risk is very important. If the LDL is above thresholds, we would add a second adjunctive LDL lowering drug. That's terrific. But if the hsCRP remains elevated, the question is, will we add an adjunctive inflammation inhibition agent? We now know that lower is better for both. And one of the key issues is these therapies are synergistic. We can add aggressive lipid lowering and we can add aggressive inflammation lowering, and that probably will improve the outcomes for our patients. So, clinical lesson number 3. The time has come for targeted anti-inflammatory therapy. The US FDA has approved the first drug, and we have many new drugs targeting things like interleukin-6 coming down the pike. Number 2, inflammation inhibition and lipid lowering are not in conflict. These are synergistic therapies that target both pieces of what drives atherosclerosis. And finally, in the near future, many of us predict that the combined use of aggressive LDL lowering and inflammation inhibiting therapies may well become standard of care for almost all of our atherosclerosis patients. Thank you so much for joining us on this vodcast, and special thanks to the American Heart Association for allowing this to move forward. I really appreciate you watching today.
Novo Nordisk is a proud sponsor of the American Heart Association's hsCRP and Systemic Inflammation Awareness and Education Initiative. The views and opinions in this activity are those of the speakers and reflect the synthesis of science. Content should not be considered as the official policy of the AHA. To get additional information, please visit learn.heart.org for more education. Thank you, and have a great day.